So we're so thankful to the Patrick E. Lee Foundation for this series and funding this series. That's Know Your Rights. It's really all about self-advocacy. Oftentimes, I myself as an advocate in this field, we focus a lot on high-level policy and strategy, but sometimes there is a missing link in terms of, how it is that we as peers can advocate for ourselves, or if you're a family and supportive friend, how can you advocate for your loved one, right? And the first tool is really education. So when we are equipped with the tools on how to support our loved ones with mental health conditions, everybody wins. And it's not a situation where we're all having to learn the hard way by going through these struggles ourselves without any tools to begin with. So the goal of this series today, the first part is about 988 and crisis response. We're here joined today with Denise Balzer and Dara Kass, who we will introduce shortly formally. But we are so grateful to have them here. They're experts on 988 and crisis response at the federal and state level. We also have Matt Shapiro, who is joining back on, who is the Director of Public Policy, Public Affairs, actually at NAMI-NYC State. And I am Kimberly Blair, the Director of Public Policy and Advocacy here at NAMI-NYC City. And so again, this is the first part of a 4-part series. The next few series will be focused on supportive housing, how to advocate yourself as a supportive housing tenant or applicant, and just housing in general as someone living with a mental health condition. And then we have mental health in the workplace. And then we'll also have mental health education. So how to advocate as a student or in the school settings. So I just want to say thank you to all who have joined, and we hope that you really do gain something from today. And now I'm going to pass it back to my colleague Matt to introduce our speakers. And then I will take a brief break before we actually start our introduction to the topic to go over some ground rules.
Okay, thank you, Kimberly. Again, I'm sorry for my little technical problem before. Just again, we're very excited for this opportunity to provide this education. Obviously, reimagining crisis situations and ensuring that a mental health crisis is met with a mental health response has been a long priority for NAMI-NYC State. And we were very active last year and not only leading the advocacy to fund the 988 system, but to pair it with mobile service and crisis stabilization services. We're very excited about that. So we are really going to talk about all the services that are coming through. Both we're going to get a federal perspective from Dara. We're going to get a state perspective from Denise and OMH. And then we're going to talk about some of the next steps, including Daniel's law, and the Handled with Care registry that we're working on with here in the Capital Region that we're very excited about. So before we jump into the speakers, did you want to just do the housekeeping real quick, Kim, about the questions and the breakouts?
Yeah, certainly. So today you'll notice that we have muted everybody in the room. It's just as a courtesy to our speakers, making sure that everybody can hear. But if at any point, if any of the speakers actually have some issues, please just let us know. We'll unmute you, but hopefully we have already rectified that. And then so in terms of the audience members, what we're going to do today is we're going to be screening questions to be able to discuss at the Q&A portion of today's session. As well as maybe for you all to bring up during your breakout sessions. So how to submit your questions, we are going to be monitoring the chat and our lovely colleagues, Haley and Caitlin, who are the unsung heroes of NAMI-NYC City and NAMI-NYC State, are going to be monitoring those questions and making sure that there are no duplicates and that we have an inclusive space in everything that's being asked. We do ask that everybody is respectful, tries to use person first language. If you don't know what that means, it means centering the people with lived experience first. So instead of saying, for example, schizophrenic as an adjective, we don't say canceric, right? So we say person with schizophrenia, or a person living with bipolar disorder. Just always centering the person first to make sure that we're humanizing people and not just reducing them down to their mental health conditions, right? We also try to stay away from saying people suffering from mental health conditions, because not everybody's actually suffering. Some people are thriving and recovering. We don't want to make assumptions of people. So while we don't expect anybody to be perfect, we do hope that we have an inclusive space, and we will be, again, screening those questions and then calling upon the speakers to then ask the question, or like a combo of asking the question and then Caitlin also maybe reading some out if we have combined a couple. So again, use the chat function for your questions. If something really is going awry, use the raise your hand function. And later we'll be putting everybody into breakout rooms. Originally we signed up with 1, 2, 3, 4, 5, 6, 7 different regions, but we actually have combined the Hudson regions to 1. So there's going to be 6 breakout rooms. So if you're in the lower mid Hudson region, we would actually like you to all join just the Hudson region. Okay. So those are housekeeping items for today. And again, any questions, you could put them in the chat and I'll be answering them now. Thank you.
Okay, great. Thank you, Kim. So let's jump in. As we know, last July, 988 was implemented across the country. It's we're going to do a top-down look at what 988 is and the other crisis services being introduced here in New York. So we are going to start with the federal perspective, and we're lucky enough to have Dara Kass from HHS to talk with us today. And again, everyone, when they got the link, should have also gotten the link to the resource guide. I want to thank Callie, who worked so hard at putting that together. I'm going to put a link to that in the chat as well, so you have it. And otherwise, I turn it over to you, Dara.
Thank you so much, Matt. Thank you, everybody, for allowing me to come here. I will introduce myself and then really kind of talk a little bit about what's going on, you know, from the federal perspective to support the needs of anybody that has any issue regarding their mental health crisis, their family's members, stuff like that. So basically, I am Dara Kass. I'm an emergency medicine physician. I am the regional director at the U.S. Department of Health and Human Services. So I work for the federal government. I am the secretary's representative here in the region, and our region is New York, New Jersey, Puerto Rico, and the U.S. Virgin Islands, and then 8 tribal nations that all exist within the borders of New York State. I am here mostly to really recap a lot of what's going on around 988. And I will open up the conversation with a little bit of an update of what's happening with 988, when it was launched, how much has gone on. And really, I would love to really open the floor for questions, concerns, experiences, comments, anything you have regarding what's going on, because it's your lived experience, your stories, the things that are happening on the ground that really we want to understand as this program continues to evolve. So many of you know 988 was a transition that occurred last July. It was a transition for the National Suicide Prevention Lifeline, and there was funding from the federal government in the form of block grants and partnerships to states. And then every state really had to figure out how to implement, you know, this transition in their own state. Now, New York had a robust plan centering in New York City, specifically the New York City Well Center. Other states have fewer resources and fewer lifeline centers, but there are many, many more call centers throughout the state. Each center is built a little differently. A lot of them existed well before even the crisis lifeline, the National Suicide Prevention Lifeline, and taken many, many numbers, including local numbers, community-based numbers. And Denise knows this way better than I do. But it was pretty remarkable the way that New York State looked at this opportunity to transition to this 3-digit number and really consolidate and coordinate care across all of the existing entities and really support them to go forward. The 988, since it's been launched in July, there have been over 2 million contacts through 988. And we're seeing, as we expected, an overwhelming number of increases in texts versus, let's say, chats or phone calls, knowing that having that spectrum of access is critically important for people in crisis. depending on what's going on in their life, right? And what crisis is different for every person. And it's important to remember that there's no predefined kind of reason you can reach out to 988. And it's important to know that it is available for anybody who needs it at any time. It's 24/7. There's a lot of data that I have on what's happened since the transition in July. And we say transition versus launch because, again, many of these centers have existed for 30 and 40 years. So the perception that this is all built at once isn't accurate. These are places that have been embedded in their communities. They know what's happening with providers. They understand about mobile response. There's a conversation I expect to have around geolocation. When 988 launched, there were a lot of questions about why geolocation was used and what would it be used for. And I'd hoped and I think that a lot of that messaging got transmitted down to the ground to the people that are going to use the system to realize that geolocation was the first step in creating an expediency for crisis response and also connectedness to a local center, but had nothing to do with emergency response, or certainly, no offense, Deputy Chief Jay, but police response. That this was never supposed to be a way that people would be involuntarily flagged to either law enforcement or anybody else that would put them at further harm. The entire team that launched the transition and that has worked on 988, both at the federal government and at the state level, has been intensely focused on the community that is going to use this resource, right? Remembering that there was to mitigate and minimize even the perception of harm, but also to make sure that at no point were any of the programs facilitated by this going to increase the risk that a vulnerable person was further marginalized or at risk or anything like that. So that's a lot of what I wanted to kind of cover in the beginning. The other thing to know is that the timeline from call to contact has dramatically decreased since the transition. In fact, there were centers, and not in New York necessarily, but even over the country, where only 40 to 50% of all the calls or contacts were even answered in some places. That is not true now. You're seeing a 98, 99% contact rate. And oftentimes, the reason that contacts are not made is actually that the caller drops, but not that the contact hasn't been successful on the other end. One of the things I told the team before this, when I was giving an anecdote, was actually a success story of my own with 988. I am an emergency medicine doctor, like I said, and I work at the Manhattan VA as a volunteer. And at one point during one of my shifts, I got a call in the ER and they said that they were a 988 operator. And they were calling back to confirm that a patient who had called them, who was a veteran, who had called for help, they were checking to make sure that they closed the person. They had recommended the person go to the emergency department, and they were closing the loop to make sure that they had. And I, as a federal employee, was really excited that that had worked, right? That somebody in crisis had called the veterans hotline, which was a 988 receiving center. They had given appropriate advice. The person was not suicidal, but was in crisis. And I think that it was important for them to know that not every crisis is a risk of suicide, but more that it's important that whatever it is, that there are resources for you. And then when the call center followed up with us, just to make sure that what they had done was successful, it shows how much they care. Right? That the person on the other end is there because they want to help people. And so I was excited about that. I don't know what the right word is. I was full with gratitude and joy that the program we'd been working to transition had really met the moment and the person who needed care had gotten it. So with that, I actually, if that's okay with you, Kim, Caitlin, Matt, I want to open the floor, or are we going to transition now to Denise? What do you want to do?
Thank you. I actually think that Caitlin, do we have any questions? Here, I unmuted you. I didn't see any questions in the chat, but if anybody would like to ask questions for our speaker, please put it in the chat. We're going to wait 15 seconds or 30 seconds. And then if not, we'll move on to the next speaker, and then we'll round out the questions at the end.
Okay, there's one question in the chat that I can answer if that's okay, Kim.
Yeah.
So it says here, I know it's been published what a person can expect in 988, but I've heard that depending on what city and state you call from, people are asked where they live when they first call. Clarify if this is true. So I will clarify that every call center is independently operated in partnership with the state that they're in, and that it's important to remember that there's going to be variability, certainly, of course, with the growth of the program and lessons learned. I will also say that call center operators are trained, and Denise can speak to more of what happens here in New York, to ask as few questions as possible in order to deliver the service that is necessary. So it's really, really important that, like I said, when somebody calls 988, you know, they're transitioned to a geolocated crisis center that has trained operators that will be able to answer the phone and ask them what their crisis is and make sure that they are getting the resources that they need, whether it's a mobile response unit or other things. But it's important to remember that where the person is only important if the service needs to be connected to the person, and the operators are trained in that way to ask, like I said, as few invasive questions as necessary in order to make sure that the person delivers gets the care that they need. If that's not happening, we all will always take feedback so we can give centers feedback on that. But it is supposed to be a safe and welcoming reception. You should not be received with adversity or hostility or any questions that you don't want to answer. That is not our goal. And I'll pass it back to you guys. Yeah, so let me say this one thing, because I see a lot of local questions popping up. There are 980 is national, okay? There is a 988 call center everywhere that covers where you live, okay? In fact, not only do we have centers that are covering all over New York, but there are wraparound services and backup services for both text and chat and phone calls around the country. So where you're routed to is specific to where your cell phone number is. But there are call centers all over the country, all over the state. There's actually, I think there's a public list of them, correct, Denise, if I'm not wrong. If you Google 988 centers, you'll find a list of them under the Substance Abuse and Mental Health Services website. In New Jersey, for example, there are 5. I think we may have like 33 in New York, if I'm not mistaken. How many do we have in New York, Denise? 11?
14.
14. Okay, see, there you go. I made up the number, but it sounded exciting. The truth is, since New York City itself is served by one large center, but I met with all the centers over the summer, so I imagined that I had met with 33, but I guess it was only 14.
Okay, great. So let's transition a little bit, and then we can take some questions at the end. I think Denise's presentation and giving a New York perspective is going to help with some of the questions that we have, and then we can carry on. So like I said, last year, NAMI New York State was very, very active in NAMI New York City as well, kind of leading the advocacy charge, not only to implement 988, but to have it properly funded, to really meet a lot of metrics that we want to see, including ensuring there'd be equality and cultural competency in our 988 system. And to Governor Hochul's credit and Office of Mental Health Commissioner Sullivan's credit, they've incorporated all of our ideas, and New York has been praised nationally from NAMI National on having the most inclusivity and diversity kind of baked into our 988 bill. So that's something we're very proud of, and we know it has been very successful so far in New York. And so hear about 988 and all the other services that New York is investing in and continuing to invest in. It's really my pleasure to introduce Denise Balzer, who's been leading the 988 implementation committee that we're proud to partner with and be a part of. And I turn it over to you, Denise.
Thank you so much. It's so nice to be with you all again this evening, and I appreciate the invitation from NAMI. There's New York State is been in the throes of the implementation of 988. And when we started, we had 13 call centers, and we had put out an RFP for 2 additional ones, one in the North Country, one in the Capital Region. So now we have 14. The Capital Region call center launched in January. So currently 14 active 988 contact centers with full 24/7 in-state coverage. So that means there's a call center that is open 24/7 throughout New York State. We also have 48 out of our 62 counties have backup coverage by a New York State 988 contact center. We've been working on that over the winter, trying to increase the number of backup centers within New York to be able to make sure that when New Yorkers call 988, that they get a 988 contact center. So I think one of the things that I just wanted to clarify or discuss was that these calls are routed by area code at this time. There has been a lot of discussion in New York State around geolocation, and we've also been talking like nationally about geo routing, which is not pinpointing exactly where someone is, but in an area, and that we would love if that was if it was going to be piloted, we would like New York State to be part of that pilot, because we think it would be really instrumental for New Yorkers to really get the services they need within New York State. Because we know in New York City, there's visitors to New York City, there's people who commute from the surrounding states. So if people are wanting to get services where they're located, that would be the most expedient way for them to do that. So that's something that we're discussing, and we're always interested in feedback related to that. As far as New York State chat and text coverage, we have in-state chat and text coverage from 4 a.m. to 8 p.m. And we're working with some current call centers within New York State, or the crisis contact centers, to expand that. We want 24-hour chat and text coverage as well. So we're working, to expand that currently. We also, we've been doing well. We're kind of been steady with an 80% call answer rate. We thought we'd be a little bit higher at this point, but there have been some just adjustments with different phone systems that have been being implemented with call centers. Some have gotten new phone systems, and they've had some glitches that have been able to, they've been able to correct, but we're moving back up to that, inching toward 100% call answer rate. Now, in the past few months, in February and March, that's the most recent data that we have. We received about 14,310 calls in February, 14,906 in March. And our speed of answer is within 28 seconds. So that's an excellent answer rate. But from comparing 2021 to 2022, we got 28,341 more calls than 2021, and 29,679 were answered in New York State by the contact center. So that's those numbers are improving, and that we're really, really proud of our contact centers. They're working hard. They're in contact with us. We meet with them regularly to troubleshoot, for them to share what's working for them to get support from each other, and then for them to just continue to work toward what our vision is for the 988 crisis contact centers as hubs for communities to be able to be connected with mobile crisis service, crisis residential services, emergency services if necessary, peer services. So we're looking at how we can expand and make sure that these night crisis contact centers are hubs for communities to be able to get information and use them as a resource. Another initiative we have within 988 is follow-up services. And Dara had talked about that, is that for some calling to make sure that people have made connections to services, but also offering a follow-up to see if there's anything else that you might need. Do you want me to call it? Do you want me to check up in a couple of days to see if you made a connection that we've given you? Do you think it would be okay if we called to see how you're doing, if someone's a little bit shaky? Just offering that opportunity for connection and support. So we're going to be putting more effort into doing that as well. And that will also help position these centers as opportunities for people to avert a crisis if needed. We don't want people to wait until the last minute when things have gotten so hard, that this is an opportunity. If you need to work through something or need support or connection or resources, that these are available to you, no matter where you are in a continuum of distress of some sort. So that's been that's our goal. As we move forward, we're going to continue. This is going to continue and continue. This coming fiscal year, our governor had promised from last year is another $60 million for New York State to implement this, and continue to implement 988. We're going to continue with that, as well as expanding our marketing and advertising of 988. I mean, we really wanted to take this first year or so to really make sure that the crisis contact centers were solid, that they had the staff they needed, that they were prepared and trained to answer calls and in an increased volume. So this May, we'll be coming out with a 988 marketing toolkit that'll be available to anyone. It has resources that will be contained within them that you can order, that you can print, ideas about how to market, ways to market 988 in your communities, whether it's a school or if you're a provider, how to incorporate it into your into anything that you've already kind of started. Maybe you had the National Suicide Prevention Lifeline logos, switching those over, putting them on your signature lines, sharing them in waiting rooms, in schools, anywhere. It could be at a bus stop or at a bar, or at, wherever you may be, that you might want to share information. So that's going to be coming as well. We also wanted to make sure that people knew that we offer most of the educational materials, and we have an OMH website, and I'll pop that in the chat so everyone has it after I'm done. And that we offer most of the educational materials in New York's top 9 languages. So you can order materials in other languages to be available, and those are English, Spanish, traditional Chinese, simplified Chinese, Bengali, Haitian Creole, Korean, Arabic, and Russian. And then I'll put the website in, and that'll tell you how you can request those kinds of materials. And then there's also, if you need, and this might take a little bit longer, but you can request materials in 28 and other languages. So we've had 50 plus requests for materials in 28 different languages. So, this is getting, the availability of these translation services is really important to us. And it's really important to the community. So that, and I can try and I'll look through the questions, if there's specific ones about where call centers are after I'm done, because that way you might be, if there's more specific questions that don't relate to everyone, I can deal with that. Now, as far as our other crisis services development, so there's 988, which we're very, very happy with the implementation of this. There's also the, expansion of mobile crisis services and connection to the 988 crisis contact centers. There's a variety of models of mobile crisis in New York State. So we use a community mobile crisis teams that have social workers and paraprofessionals and peers. We also have some co-response models with law enforcement and a social worker. New York City's piloting a Be Heard service, which is EMS social worker that's activated through 911, but also comprehensive psychiatric emergency programs in New York City and across New York State have mobile outreach services. Those are licensed professionals, and social workers are peers. So there's a number of different models that are currently in effect in New York State. We're going to be putting out a grant opportunity to develop mobile crisis services where there are none, none have been identified by the county directors of community services, that there's no service for children, there's no service for adults. So we want to at least begin the development of those underserved communities. And then I'm sure, along with our conversation related to Daniel's Law and how that goes forward, the development and expansion of mobile crisis services will be a priority for New York State. As far as our crisis residential programs, these have been the crisis respite programs that were available across New York State previously. There were crisis residential programs that were 3 beds that were located within a community residence. That was a grant that was several years ago that is continually being renewed. And then we published regulations that allow for the licensure of crisis residential programs as well. And those are supportive, which is a peer-led model, intensive, which includes treatment services, and then children's crisis residences. So we're helping with the licensing process, trying to help with standards and efficient ways to access those services. So we have a learning collaborative with our crisis residential programs in New York State now. And then recently we published requests for proposal for the development of crisis stabilization centers across New York State. So we've awarded 21 crisis stabilization centers, both supportive, which is a type of a living room model, and an intensive crisis stabilization center that has a complete array of supportive and treatment services on site. So the living room models have the supportive services on site, but they have to have a direct link and availability of service, the treatment services, but the intensive have them on site. And this is a project between OMH and OASAS, the Office of Addiction Services and Supports. So we're excited about those moving forward. We anticipate that that programs will be fully licensed. Some of them, it's going to be a gradual process because some are using funds to build out spaces. Starting probably June through the end of the year, we'll see them start to open up across the state, along with those that have already been in operation, like Dutchess, maybe Dash and Suffolk County, that will be going through the licensing process as well. So we're really excited about the opportunity for those programs to open. But one of the most important things about all of these crisis services that we've been discussing is the importance of peers as part of the staffing configuration of these programs, and also the intention of the peer specialists, of the peer services, is that we don't want these services delivered business as usual, as we have, created, collaborated with experts that have been providing these services, and we want to make sure that they truly are person-centered. Like, that is our intention with helping with the support and implementation of these programs, is that we have a team that includes peers, that peer voice is important, and that we implement them with that foremost in our mind. That this is not just an emergency room lights or these kind of programs. We really want to make an impact and make some changes in the way that services are delivered, particularly in crisis when people are at their most vulnerable. So those are the updates of the peer or the crisis services that we've discussed. Now, we're also providing some funding for the comprehensive psychiatric emergency programs to include peer bridgers in their staffing. And we're working very closely with them about what that actually means, because they're not used to that model. We want to make sure that peer bridgers are doing what the intention of the peer bridger is to help connect with people, not force treatment, to help people have their own voice, their own choice, and help them move on and get services that they think that they need, that they want, and that we can help them access, and that it's not coercive and it's supportive. And so that's a way to help kind of change some of the culture of emergency room psychiatric service delivery. So those are the things that are foremost on our mind right now, and as we move forward with the crisis service development in the coming year.
Great. Well, thank you so much, Denise. It's really exciting to see everything that New York is doing on this, and we really are a national leader. So it's something we can be very proud about. I know there are a lot of questions that we'll get to about anonymity in calling the line, especially as people call you back, and some the geo-tracking questions. I know Dara
Yep.
kind of touched on that earlier, and that's
Yep.
something I know NAMI National has been working on with HHS as well, especially via New York. We know the governor's lobbyist in DC has been working on this issue, and it's something we do understand that needs to get smoothed out and is being worked on. So before we open up for questions, Susan, we're running a little behind. I want to open up to some of the next steps. And we're really so fortunate to have so many partners in taking the next steps. What are the ones I want to introduce first? We'll do Handle with Care and then Daniel's Law, which I know is reversed, but I also want to be cognizant of Jay's time. So, we've partnered with police departments, non-police departments to really, like I say, reimagine crisis situations. And we're so lucky to have found so many incredible partners, including Deputy Chief James Gerace of the Colonie Police Department, who was actually the recipient of our 2020 Criminal Justice Award and continues to honor that and come up with new things. And something that we're very, very excited about is this new partnership we're going to be launching with the town of Colonie, which hopefully we may even be able to take statewide to better give police more tools to handle crisis situations. And Jay, I have the link, so I'll put that up for the Handle with Care, but I'll let you take it from there, and then I'll share my screen so people can see it.
Yeah, thanks, Matt. Thanks everybody for letting me join you. Matt has the links. So trying to get crisis response down to the local level. Yeah, this is a draft website, so it's not live yet. But what our goal was in the town of Colonie, so we have a great relationship with our county mobile crisis team. We have a great relationship with NAMI-NYC. We're always looking for ways to improve crisis response service. So our police department recognizes that given the way the world is right now, the Colonie Police Department is going to continue to respond in these type of events. It's just the reality of the situation. So we're trying to figure out what better ways can we deliver care. So what we came up with was a registry that is available to families or people that have sometimes frequent contacts with our police agency. And so the situation we imagined, or the scenario we imagine with this, is we have a number of families, especially parents, who have maybe some adolescent children or adult children that they care for, that can have, go into crisis from now and again. And we wanted to offer a registry where those families or the person that may fall into crisis wants the police to have certain information on how to better deal with them, or how to connect with them and build rapport more rapidly, maybe than just some officer that's never been to that particular house. So to give you an example, we have an adult individual lives with his grandmother, but he's a really large boy, and he'll frequently start smashing up his grandmother's house. And he was one of the ones that we had in mind. So there's a few officers that can connect with him really easily. And one of the things that he likes to talk about is the insane clown posse. And so if one of our officers that has dealt with him knows he likes to talk about the insane clown posse, he'll immediately put down whatever implement he has in his hands. He'll stop smashing things and he'll want to talk to the police officers there about the insane clown posse, and he calms down. It's almost immediate. But the trouble is what do you do if we've got rookie police officers that don't know who he is or have never been to that particular house? So how we envision our registry is our officers working with families to register their individual. And Matt, if you can scroll a little bit down for me. What I really wanted to drive at was triggers or things that we want to avoid, like self-reporting, and calming methods, or things that'll bring this particular individual that you'd be registering joy. So it helps us develop that rapport a lot quicker. Our officers are enthusiastic about it. The families, some of the families that we deal with are excited that we would be able to, they'd be able to provide this information, because some of them are scared, right? That officer that's going to come doesn't know their child or know their loved one, and they just want us to have this information. So how it's going to work is if a family member were to register or the person were to self-register with us at the local level, this information would go into our records management system, and it gets linked to a person by name, vehicle, and address. So it's a special needs registry. So anytime an officer was dispatched to a house where the person was registered with us, and it's voluntarily, the officers would have this immediate access to this information. And so it's like being able to have an experienced street cop who's dealt with a particular individual and has that rapport. We're transferring that information to maybe some other of our younger officers that don't actually have it. So that was one of the goals that we were looking at with this. And then we also have some autistic nonverbal individuals in our town that will kind of wander, and Alzheimer patients. So we do participate in Project Lifesaver, but we've come across some of these individuals, and some of us who've been on the job a long time know exactly who they are. We know where they live, but there are other officers that'll come up with somebody and not know where to bring them. So you can do a group search in our computer-aided dispatch system for those that are registered in our persons or special needs registries. And then the picture will come up and where they live, and we can bring them back, safely to loved ones. And it helps expedite that process. So that's, in a nutshell, a quick summary of what we're trying to accomplish with this Handle with Care registry and supported through NAMI and trying to get the word out.
Well, thank you so much, Jay. And we are so honored to partner with you. Like we always say, kind of the tagline of this event, knowledge is power, right? So giving officers the knowledge that they would need to best intervene is so important. In the handout that we sent to everybody too, in the resource guide, one of the things we talk about is how to improve communication to police officers and first responders. And one of the things, anyone who's been in a crisis situation knows it can be such a stressful and decombobulating type of event where it's really hard to remember everything. So one way to ensure a best outcome is to write everything down and have it right in the house, kind of like a advanced directive. So if a first responder does come and you're not thinking clearly, whether it's you or your loved one in the situation, you can hand the information to the responder and say kind of the same things we're trying to capture with Handle with Care. What are some trigger words? What are some calming words? And try to give the first responder and the officer the information they need to generate the best results. So again, and that's our right too, to have that information available to people to generate the best outcome. So we're so grateful to be able to do it on a grand scale with the town of Colonie. But again, everyone has that opportunity to write out things that you think is best information for an officer or a first responder to know. And of course, we are so lucky to have dedicated police officers like Deputy Chief Gerace and the town of Colonie that are really coming up with constant ways to not only deliver crisis intervention team services, but really go the extra step. But we know it's really not their job to intervene with people with mental illness. And again, that's a big part of reimagining crisis situations, is not having to rely on police, even the most trained ones and the most excellent ones. It's really not their job. They're not psychiatrists, they're not therapists. So whenever possible, we do want to see mental health responders, respond to these situations to make life easier for police and generate better results. So, Kimberly, I know you're going to talk a little bit about Daniel's Law as one of the next steps we're looking to see in New York. So I turn it over to you, my friend.
Thank you, Matthew, and thank you to all who have joined us today to talk about 9/11 crisis response. Before I begin, I forgot to mention in the introduction, I mentioned before, my name is Kimberly Blair. I'm the Director of Public Policy and Advocacy here at NAMI-NYC, but more importantly, I also identify as a peer or someone who has lived experience living with mental health conditions. I'm also the daughter of a retired police officer. So when we're talking about crisis response and the movement and what could actually be coming down the pike in this next year, that is the lived experience that I am coming from, as well as informed by many other peer specialists and peers that we work with. So what I'd like to talk to you all about is what actually could be coming down the pike in terms of a statewide non-police crisis response. As our colleagues mentioned before, it's going to be inevitable that there are times in which people with lived experience are having run-ins with law enforcement, but we want to make sure that law enforcement are actually having the time and the capacity to be doing their job, which is public safety and not necessarily a public health response, right? So the movement that we all have been pushing for at a statewide level is to make sure that there are statewide crisis teams that consist of peer specialists, so that for those who don't know about this jargon, peers, again, someone with lived experience, but a peer specialist is someone who has certification, who has gone through training. Some programs in other states have gone up to over 500 hours in training before joining these teams, where they also have had hands-on training as well. So it's not just behind a computer. And so peer specialists, as well as other mental health professionals, we're trying to pair those with independent or unaffiliated EMTs. So emergency medical technicians who really know best how to respond to people in crisis. The peers are really important on these teams because they themselves have lived experience and have gone through crisis and have made it through recovery, have been able to come on the other side. So a lot of those calming techniques that were just mentioned before, those are also similar techniques that peers would utilize when responding to mental health crisis call. However, say that someone is not registered or hasn't actually identified what their crisis is, a peer who has that lived experience could identify the situation and try different tactics, such as motivational interviewing, to try to get to a point where you can de-escalate someone in crisis. Now, the reason I say that we're moving towards this is because right now, Daniel's Law, so it's Senate Bill 2398 and Assembly Bill 2210, in case anyone wants to look it up. There has been a big push and in the New York State Legislature to try to implement and pass and enact this movement towards these regional councils that would then determine what is the best crisis response mechanism depending on that locality. So for example, we all know what would work best in the capital region might not work best in New York City. And we want to make sure that everybody has certain guidelines or standards that they follow on these teams, including having medical professionals first, not promoting co-response with police, making sure that there are a whole bunch of tenets that are standardized across the board, right? But that the nuances in terms of how we would respond based off of cultural diversity or based off of regional diversity are embedded in those regional councils who would, again, be setting what the crisis teams would look like. Those regional councils would also serve as accountability mechanisms in case something goes wrong with those crisis response teams, or there are any adjustments that need to be made, or any grievances or complaints that need to be rectified. So right now in the legislature, they're pushing for 10 million to pilot this, and that's why we thought it was very important for everybody to be informed, because this actually could be a very viable thing coming up in the next year. So when we think of how this integrates with some of the concepts that we discussed before, we discussed 988. The whole goal is that we move away from a 911 mechanism for launching crisis response teams and start moving towards 988. But in order to really have that as a full functioning system with this new crisis response teams that we are envisioning for the state, we need to make sure that we fix some of those geolocation issues that were mentioned before by my colleagues Dara and Denise, and that our communities also know about 988, right? We need to make sure that we are ourselves, when we talk about self-advocacy, we're also going to our neighbors, going to our other peers who live with mental health conditions and telling them, hey, there's this 3-digit crisis line that you can call instead of 911 to get help when you need it. So that's really what I wanted to focus on. And I think that now I'm going to turn it back to my colleague, Matt Shapiro, so that we can move towards some short question and answers because we're running a little behind, and then we'll move on to the breakout rooms. Thank you.
Thanks. I think Caitlin was monitoring the questions. I've been looking at some of them and answering the easy ones, like, will the recording be made available? Yes, it will. I see Jay answered some questions about the registry. I'm just looking, Rena, yes, families can register someone who's not a minor without their, I believe so, yes.
Matthew, I actually have some screen questions here.
Okay.
So again, for the follow-ups, I thought it was anonymous. How can someone in distress get information and remain anonymous? I'm assuming that this question is in regards to 988. Unfortunately, Dara had to leave, but we can answer this.
Denise, though, who can
Oh yeah, let's spotlight Denise. Actually, I'm going to bring back all of our speakers that are still here, if possible. That way, that as the questions come, we can just unmute ourselves and speak. So, Denise, for follow-ups with 988, I thought it was anonymous. How can someone in distress get information and remain anonymous?
The only way that you would be identified would be if you shared your name. Your phone number is not going to be recorded. If you want to share that so that you can tell people who you are, or you want to follow up, you can do that. But if you just want resources or connection to resources, those can be given to you based on what location you're looking for resources in. So your phone call can be completely anonymous.
Awesome. Next question, actually for Denise as well, since we're already on the 988 topic. What is the first step when one calls 988? Is there an established protocol?
I think when you call 988, there'll be, dial 1 if you'd like to if you'd like the Veterans Crisis Line, or dial 2 if you want Spanish. And then you'll be routed to a call, and then someone will ask you, how they can help. And then start to, hear about why you're calling, and then go from there. That should be the protocol for answering 988.
Definitely. And I will also say, because, we're trying to promote knowledge is power. So for anybody who's actually, who might be a caller from New York City, we wanted to let you know that since NYC Well is the answering call center for 988 here, if you have any of the area codes that correspond to New York City, so 917-212, 646-347-718. You already know 917, the 917, those are the real ancient ones. We love that. And the 212s.
212, very ancient. I think that's the most ancient.
Ancient. I'm saying if you have one of those, you're special. Hold on to it. So anyways, back to what's important. If you get routed to the NYC Well call center, I just wanted to let everybody know that you have the ability to request a peer specialist if you want to. So whoever is first available on the phone will be the person to answer. It's either going to be a licensed clinician, usually a social worker, or a peer specialist. But if you feel more comfortable with either a clinician or a specialist, it's up to your choosing. You do have the power to make that request and ask for it. So I wanted to let you know that. Also, I believe the NYC Well line has the ability to connect to an interpretation service, I believe. So if you have other languages that are not Spanish, I know that they have some ways that they've been dealing with that, but I know that moving forward, NYC Well has been trying to see how can we be more language inclusive. So stay tuned for that information.
Yeah. All the crisis contact centers have access to a language line.
Yeah.
Awesome.
And it was great to see someone had put in the chat earlier that they have had very positive experiences calling 988 on several occasions. And a couple of weeks ago, I had someone reach out to me to let me know that they had done the 988 over the computer, kind of like chat function, and that it was very effective for them as well. And we're really impressed with the mechanism to handle that chat. I almost said call, but chat. So yeah, we are, the feedback that we've heard has all been very, very positive about people's experiences. And again, so as is still a work in progress, hearing that it's delivering what people want is very encouraging. And I saw someone ask, can anyone of any age call 988? And I believe so. There's no restrictions on it. And again, it is a nice option for people who, again, maybe in your community, you don't have a child psychiatrist or a clinic in a school-based clinic, which is another one of the programs that the governor has advanced that we're really supportive of. But it is available to everyone, and that's what it's there for, to really be a lifeline in communities that don't have those connections. So anyone of any age can take advantage of that.
There's also something else I would like to add to that answer. We often think of the person in crisis calling 988, but oftentimes, just coming from a peer perspective, sometimes when we're in crisis, we don't even know what's the first step, right? Because we're so, in the moment, right? So if you're actually a family member or a friend, caregiver, you actually could call 988 as a alternative to 911 in order to call for your loved one to see if maybe that person on the line could help you use some de-escalation tactics with your loved one. We have had some of our NAMI-NYC members use it in that way, and it actually has proved positive to them. So check it out if you'd like. And also some people, the goal is obviously crisis response, but some people know the warning signs of when they're about to enter crises and have also used 988 to avert crisis. So even if you're like in the ideation stages and you're feeling like you're moving towards planning in terms of suicidal ideation, always feel free to use this as a mechanism as well. Okay, so the next question, and I know we're running up on time, we're gonna go
one more.
The next one is, when it comes to mobile crisis teams, how long are response times on average? So those actually really are dependent on region. We do have some data that we can follow up with in terms of nationwide 988 call times. It shows how many calls are answered, how many calls have dropped, how many texts were answered versus chats, because some people don't know that they could actually text 988 as well. That's something you should know about. Or you could chat on the website, right? But in New York City, I believe that it was last like oh no, those are the Be Heard numbers. I actually don't know, so I won't say that on the record without knowing. But Denise, do you know, do you have an idea
About Be Heard?
No, around the how long are response times on average?
They do depend. It depends on, it varies around the state because response is so variable around the state that services are delivered in very different ways. Our expectation is that if you're an approved mobile crisis provider through the state, is that you respond as soon as possible, no more than 3 hours. And that seems like a lot, and it kind of is a lot, but it at least puts some guardrails up around, the expectations. Because the geography of New York State is so varied. You have an urban area that it might take a long time to get from one borough to another, or across a a mountain. So it's varied across the state. But we really want to work toward, bringing it as quickly as possible to people in need.
Yeah, I can say that from the New York City perspective, Be Heard is somewhere between 12 and 16 minutes. I think the fastest they got in 2022 was 12 and 14 minutes.
Yeah.
So they're getting better at their response time.
And they're connected to EMS. They're connected to the 911 and EMS system, which is an emergency response, where mobile crisis isn't categorized as an emergency response.
Yeah, so I think these are all the questions we can answer for right now, but if after the breakout rooms we have the opportunity to, we obviously will we'll come back and Matt and I will try to answer as many with some of the breakout specialists. So Matt, is there anything you'd like to say before we actually open up the breakout rooms?
No, I just wanted to thank, of course, all of our speakers, Dara, Denise, and Deputy Chief Jay. You know, again, we're so lucky to have such good partners here to advance all these crisis services. And really, it takes a team effort to reimagine crisis. And we have an incredible team here in New York, both on the state level and locally as well. So that's kind of a nice transition to hear about the breakout rooms and how these crisis services are being offered locally. Now, I was just kind of looking, Kim, they're numbered. Do you want me just to go over what room is what number?
Actually, I can do that right now. It should come up with the name, but I'll read them out right now. And I will read out who is the speaker as well. So we have here for Long Island, it's room 1, and the speaker is Sherry Kaplan. Thank you, Sherry. She's going to be speaking on both Nassau and Suffolk County. Then for New York City, it's actually me, and I'm going to be serving as a representative from CCIT NYC, which stands for Correct Crisis Intervention Today of New York City. For the Hudson region, which is room number 3, we have Matt Shapiro. And then for the Mid-Hudson region, which is room number 4, we have Steve Mikio.
No, we're gonna do 3 and 4 together. I'm gonna do both of them.
Oh, sorry. I only have one Hudson region down. I don't know why I said that.
Putnam, Rockland, Westchester, Orange, and Dutchess will all be in room 3 with me.
Okay, awesome. Yeah. So the rooms will say it. So the next room is actually going to be the Capital Region with Kate Flanagan. Thank you, Kate. The room after that is Central New York. So think Utica, Syracuse, those regions. That's going to be Andrea Morgia. And then we have Western New York. I think Rochester, Buffalo, those are 2 big areas around there. It's going to be Colleen Christich. So I'm going to make the breakout rooms live. And if you have any questions, feel free to stay in the main room. And then Haley or Caitlin will help you get into the breakout room that's respective to your region. But please feel free to join the breakout rooms now.
Yeah, I don't think it came up right, Kim.
Does it not say to join the breakout rooms?
No, it shows that there's 6 rooms, but you can't join them.
Okay, one moment. Apologies.
Oh, there we go. I think that looks.
Okay, it should work now. Please let me know if not. I changed the settings so that participants can join the rooms. Oh, thank goodness. Okay. Apologies.
People getting in there. Local breakout rooms. Oh, yeah. Is that, we really have to ensure that as we start to market 988, that we're going to have to do it differently in every community. I know, Kimberly, you mentioned before that what might work in the capital region might not work in New York City or in Buffalo or in Syracuse, you name it. So again, especially communities that have built distrust to not only 911, but to certainly 3-digit numbers as a whole. getting them to understand what 988 is and the differences. It's going to be a lot of work. It's going to take a lot of commitment, both from NAMI and from OMH and the state. But I mean, the commitment is there. And like I said, our 988 bill has the most statutes in our bill to ensure that there's equality and there's diversity and that it's culturally competent. That has always been a major part of our argument. So again, and a lot of that goes into explaining the difference between 911 and 988. So thank you for whoever asked that question.
So I'm gonna go through these questions somewhat quickly, but I will also slow down. It's just some of these can be answered right away. All right, I'm not sure that we're not supposed to call 311 in Rockland County. Confusion. Ready? The whole movement is to move away from it and to dial 988 because they are the experts. I know in Rockland County, maybe in the past, they've used it for the behavioral health response teams to get launched, but actually there's a better way to connect to the behavioral health response teams in Rockland County. And I can put the number in the chat. It's a hotline. It's 845-517-0400. So that's a little longer than 988, but we want to make sure that everybody's informed that there are better mechanisms because it might take some delay. And if you're in crisis, you want help now, right? Okay, isn't it also true that if someone calls 988, the call could be sent to 911 if the call taker determines there's an imminent risk of harm? So there are some areas that would be determined by any clinician. Obviously, if someone is a threat to themselves or others, it's usually if there's a gun involved. Those are the real red areas where there would be, potential for referral to 911 dispatch. However, I just want you to know that, again, there's nobody tracking your location. There's nobody as of now, and there will be protocols set before geolocation rolls out, so that all dispatchers would understand on both ends, 911 and 988, on how to proceed and how to refer to each other, right? But if at any point, this is knowledge is power. If at any point you feel uncomfortable with the fact that somebody maybe might be acting outside of their job and like referring you to 911, just hang up. That's literally it. Just hang up, because so long as 911 dispatch doesn't pick up, then they won't know your geolocation. But I just will again reiterate that 988 is supposed to be confidential, it's supposed to be free, and it's supposed to be 24/7. And those are the goals. And the goal is never to put people in a position where we're trying to include the police when they're not necessary. Okay, so when 988 says it's escalating, do they not contact someone in local for a 911 emergency response? There's a triage service. Usually, like, many questions are asked before making a determination like that. So if someone's in a tier 1 state where they're contemplating suicidal execution or planning stage, right? There are ways clinicians use to de-escalate, and that is always the goal first. The goal first is de-escalation, and it's not to actually launch 911 emergency response or any emergency response teams. In fact, the way under New York State, we can only speak for New York State, okay? But the way our state works is that a lot of the call centers are trained to have voluntary like motivational interviewing and like voluntary commitment in the event that the clinician thinks that a mobile crisis team is appropriate. So what does that mean? Maybe my language wasn't so precise because the use of commitment is not nice, but it's supposed to be voluntary throughout the process. So they ask you questions and what it is that you actually want to see in terms of a response at this moment, right? And if that means staying on the phone with you, if that means, finding different other tactics, then that's what they're going to do. But if in their best clinical purview or professional experience, if they do think that a mobile crisis team is necessary, they're going to tell you, and they're going to ask they're going to try to find a way to get you to contemplate that, but they can't launch anything without your approval. Okay.
Yeah, Kim, can I take a question here?
Yeah.
That I see that I want to answer. Someone at CKB, are police officers ever expected to be trained at all on mental health crisis response because of the possibility of a call being referred to them? So that is a great question, and we talked about this a little bit before that. You know, NAMI New York State's been very active in crisis intervention teams and crisis intervention team trainings. You know, I always present at CIT trainings held by Albany County. I see Katie Flanagan here is posting. She actually does our CIT trainings. And again, you know, the police officers aren't mandated to take these, and we kind of don't want them mandated. We want officers to take it because they're interested in being better, you know, better equipped to handle these situations. And again, not to embarrass Jay here, but you know, we have, again, the town of Colonie and the great CIT officers that we have. You know, when we gave Jay the 2020 Criminal Justice Award, it was because of the situation that happened here in the Capital District. And was it a Walmart or a Target? I forget, where the individual said they had a gun. It turned out to be a toy gun, but still it looked like a gun. And the trained police officers at in Colonie de-escalated the situation. Nobody got hurt. And there was one where I think a lot of times when people first hear a gun, that it could have become, it was a Walmart, could have escalated very quickly. So again, we want police trained in CIT. We want them to want to take the training. And I mentioned before that NAMI is going to be working on some new resources on this and how to connect with police. Hopefully we'll have it ready in the fall. But part of that's going to be how to communicate to police on all levels. So if you're going to be on a CIT training as one of the peer or family members, how to tell your story effectively to a group of first responders, how to advocate locally for CIT and other crisis services, and then how to discuss those needs. And if, say, your police department doesn't do a CIT training, how to communicate the need for that to those departments too. So again, knowledge is power, communication is power, and you know, we do want to see police officers trained. We hear success stories all the time. I know tomorrow night in Westchester, they're going to be hosting an event showing the film Ernie and Joe, Crisis Cops, that detail very successful CIT program. And you know, we'll also be discussing that in much more detail at our November conference as well. You know, the CIT and crisis response is always a big part of our annual conference, and we'll be sending out more information about that shortly too, and hope people can attend. And again, we'll always have scholarships for those available as well. And we do give scholarship to police officers so they can come to the conference and learn this information and be a part of the team. We always talk about a recovery team, right? You know, we usually say an individual, the family, and the provider working together, but we do see police as part of the recovery team. And one of the really nice things of our conference last year was getting to see so many of our members interact with the officers who were there and tell their stories and share their experiences so people can see what we really deal with. Because a lot of times when an officer does intervene with someone in crisis, they see the individual and their family at their worst, one of their worst moments. So to be able to, you know, not be in a crisis situation and explain these things, I think it was very beneficial and sets a great foundation.
Okay, so we're coming up on time. Well, actually, we are past time. However, I just wanted to just clarify that when we're saying we, actually NAMI New York State promotes CIT, but that is not a belief of NAMI New York City. So I just wanted to do some clarification to make sure that everybody's clear on different organizations' stance on that. And yes, CIT training is voluntary. In New York City, we at one point trained 70% of the force, and our rates actually went in the opposite direction of what we wanted to see in terms of positive outcomes. So we're very happy that sometimes that CIT works in other regions, but that's not the unfortunate outcome for every region across New York City. So I mean, not New York State. There are many regions that actually need a different form of crisis intervention, and that's why we're trying to move towards different crisis response that center mental health professionals such as clinicians, social workers, and peer specialists, as well as unaffiliated medics. So we see many questions. What I'm doing is I'm saving the chat, and hopefully when we send some follow-up information, most of those questions are being addressed in the email. However, if there isn't anything that's addressed, you definitely can feel free to contact the organizer of the event or advocacy@NAMI-NYC.org, and we can connect you with respective NAMI affiliates, as well as local crisis community centers near you. I know that there was some information that might be missing with Central New York, but we'll make sure that a lot of that is beefed up in the response that we will be sending out in the written materials. So just thank you to all the speakers, all the audience members, all your questions, Matt Shapiro, the whole team for being able to be present today and learn more. And we really hope that this session was helpful in having people being able to navigate 988 and crisis response mechanisms throughout our state. And we hope that we see you for the next one, right, Matt Shapiro?
Yeah, and I accidentally put link to KRL3. It's actually the second one on mental health housing. The link is in there. I'll throw it in there one more time. So if people want to register for the next one, which is on mental health housing services, and part of this conversation, crisis housing services too, which Denise touched on as well. So it'll be a bit of a continuation of this discussion, and obviously housing is such a big issue for us. So we're really excited to answer many of your questions and let you know what your rights are. So like Kim said, I just want to thank everyone again for attending on a weeknight. Thank Kimberly, Caitlin, Haley, the whole team that put this together. Obviously the Patrick P. Lee Foundation. So grateful for their funding for this and giving us this tremendous opportunity, and look forward to, again, sending out more information to everyone and seeing everyone in June to discuss mental health housing. So have a great night, everyone. Thank you.